Hello and welcome to the UK NEQAS Immunology, Immunochemistry and Allergy webinar series, Mysteries of Myeloma. I'm Dina Patel, Scientific Director of UK NEQAS IIA, and I'm proud to introduce today's webinar session, Diagnostic Testing for Myeloma Challenges and Pitfalls, Part 2. I'm sure you'll all be very familiar with Zoom by now, but a few housekeeping rules so that we're all aware of how the webinar will be formatted today. So the speaker will present their slides, followed by a Q&A session with our speaker panel. There is quite a lot of information to relay by the speaker today, so if we do run out of time, to answer all the questions, we'll pick these up in our week 5 session. All the questions can be viewed by the attendees here today. So if you think there's a particular question that's really important and you definitely want answering today, please feel free to upvote the question by clicking on the thumbs up icon next to the question. So the more the question is upvoted, the more likely it will be asked. We won't be using the chat function to answer any questions today. So if you do have any questions, please make sure you use the Q&A section. We are recording the webinar and we will be sending links to the on-demand recording to all the registered delegates in the next few weeks. Unfortunately, it isn't possible for us to provide CPD points for the webinar series as we can't verify attendance, but registration certificates will be emailed to you, and we suggest for CPD purposes you can write a brief statement on a reflective learning piece and submit as necessary. So without further ado, it's my privilege to introduce our speaker, Dr. Joanna Sheldon. Jo has worked in the Protein Reference Unit at St George's Hospital, London for about 40 years, from being a trainee biomedical scientist at the bench to becoming a consultant and the Protein Reference Unit Director. Jo has always liked the hands-on aspects of the protein lab and has considerable experience of manual immunoassay, electrophoresis and immunofixation techniques. Teaching and training is an integral part of the protein reference units, and many of you will know Jo from seminars or scientific meetings on proteins and immunology. So, Jo, if you could share your slides with us, please, and then I'll hand over to you.
Thanks, Dina. Okay, that's a yes. Down here. This one. Okay, Dina, tell me, does that work?
Yep, we can see those slides, Jo.
Fantastic. Okay, brilliant. Well, lovely to see you all again. As we were waiting to come on, I was watching the number of participants tick up into the high 300. So hopefully there's a good few hundred delegates on this webinar, which is absolutely super. It's super to see you all. And really just to remind you that UK NEQAS has organised it, but with significant support from Myeloma UK, and part of the people on this webinar may also be patients or clinicians who are interested because they've seen the webinars coming out in adverts from Myeloma UK. So while we're thanking people, I think we've got to thank Dina and Jen, who are integral to putting this together, but also David, Hazel and Carol at UK NEQAS, who are collecting all the questions that you're typing to them and sorting them and helping direct the questions to us for the afternoon. But also to thank people from New Zealand and Australia who are participating in these webinars. And you know, when a lot of us are thinking, oh, it's 3:30, it's time to go home soon, Australia and New Zealand are getting up in the middle of the night to join these webinars. So anybody from the Antibodies who are here, welcome and thanks very much for attending. So just to remind you, what did we cover last meeting? Well, we talked about the service to patients and how that's absolutely central to what we're doing. And the integrity of the lab in this investigation of patients with myeloma and other B-cell dyscrasias. And really just to remind you, what did we cover last meeting? Well, we talked about the service to patients and how that's absolutely central to what we're doing. And the integrity of the lab in this investigation of patients with myeloma and other B-cell dyscrasias. And really just to remind you, what did we cover last meeting? Well, we talked about the We also heard in week 1 how actually we do need to improve what we're doing because there are still significant delays in the diagnosis of myeloma, which have a detrimental impact on patients. We suggested using the GP diagnostic tool as a very useful thing for both the lab and for the GPs and the clinicians. Spoke about the basic requirements of the lab sort of protein testing, electrophoresis, immunoglobulins, and urine electrophoresis, and the very basic interpretation. Now, if we had a whole 5 weeks just to do the lab side, we could go into all of these things in a little bit more detail, but we are limited in time. So we're going to skim over things, hopefully give you a flavour of what we should be doing, and hopefully generate some questions that you can ask us either on the questions function, or actually send cases into us to discuss in week 5. So in this session, we're going to talk about typing paraproteins, things that interfere with the electrophoresis, things like antibiotics, contrast media, and some of the newer drugs, things like Daratumumab and isatuximab, which are both drugs that are anti-CD38 antibodies that will appear on protein electrophoresis. We'll briefly talk about paraprotein quantification, talk about serum-free light chains, and then a big area, an area that's very important because the lab doesn't exist in isolation. We can do the tests, and the tests are actually relatively easy to do, but it's that added value of the reporting, looking at cumulative results and making useful comments, and finally that communication of results that makes a good lab an excellent lab in this kind of service. So first of all, let's talk about typing of paraproteins. And first of all, we have to decide which samples we should, and I've used Immunofix, but which samples should we type for a paraprotein? Obviously, anything that has an unusual band on the serum protein electrophoresis. But at St George's, we would also type anything with a raised IgA or IgM concentration without obvious beta gamma fusion, because there might be a little monoclonal sitting in there under the beta, or even in the alpha region of the electrophoresis. We also type samples that have unexplained immune suppression, for example, a low IgA or IgM concentration. Don't forget that IgM in particular is a very sensitive marker of secondary immune suppression. IgM has a half-life of only a few days, and actually the concentration is independent of serum concentration. So the half-life is independent of serum concentration. So if you completely stop your IgM production today, in 3 to 5 days, it will have halved and carry on so. So that slightly low IgM is an early indicator or an indicator of some secondary immune suppression. And in patients who are elderly or may have other symptoms that could be considered to be associated with B-cell malignancy, it's worth checking the immunofixation just once, don't keep doing it. Unexplained renal impairment, where the clinicians, or we may be thinking renal amyloid. Unexplained cardiac failure, where we may be thinking of cardiac amyloid. If anything on the clinical details, say pathological fractures, and we'll always fix the serum if we find monoclonal light chains in the urine. And we also use it to detect complete remission in patients post-treatment, both drug treatment, but also stem cell transplant treatment. And we're also looking at immunofixation to look at relapse. If the immunoglobulin of a paraprotein type is increasing, and we want to confirm whether that's a little monoclonal reappearing or polyclonal. So we also type unusual bands on urine electrophoresis, and a urine that we've not really seen before with any proteins other than albumin. That's quite a long list, and we generate quite a lot of immunofixations. But that's also to do with the spectrum of samples that we see. But I think it's also important if you do these tests, you do them properly, you do them once and you do them properly. And it's as important for a clinician or a patient to say, we haven't found a paraprotein, even though this IgA is high, or we haven't found a paraprotein and you're thinking of cardiac amyloid, maybe we should do the free light chain. So a negative finding can be as important as a positive one. And we have 2 main techniques for immunofix or immunotyping. So the immunofixation, that manual gel-based technique, versus the automated immunotyping method. The automation, but the immunofixation is more sensitive than the electrophoresis. The immunofixation, you will see a band on the immunofix that you won't see on the electrophoresis. It gives you a positive signal.
Whereas the immunotyping has essentially the same sensitivity as the capillary electrophoresis separation. You actually need to be able to see the band clearly to be able to then type it, because it may have moved or disappeared on the immunotyping. So it's essentially a negative signal. The immunofixation is incredibly flexible. You can muckle around with the dilutions. You can do a lot of things with the immunofixation, but the immunotyping is not flexible at all. Immunofixation is better for detecting a polyclonal gamma versus a paraprotein, and the immunotyping isn't so good as distinguishing that polygamma versus a diffuse paraprotein. We do urines on immunofixation, you can't use them on immunotyping, and immunofixation is pretty much suitable for all paraproteins in serum and urine. Immunotyping is fine if you're looking for a big band, a big obvious paraprotein, but you may easily miss the more subtle bands that you would see on gel, you would see on immunofix, but you may not detect them on immunotyping. But with both of these systems, high-level interpretation is absolutely essential. They are not, it's not numerical, it's an interpretive skill, and you need high-level interpretation. Right, so this is an example of immunofixation and immunotyping. This is not the same sample, but you can see here on the immunofixation, this is a severe immunofix, where we're seeing a very obvious IgG lambda paraprotein and a nice band of retained lambda Bence-Jones protein. And over here, different sample, you can see that this is I'll just remind people who aren't familiar with immunotyping, you take the sample and you add it to a number of wells. Each well has a different antibody in. So this is this well will have anti-IgG in it, this anti-IgA, etc. And when the antigen, the paraprotein, and the antibody, somebody's knocking on my door, I knew this was going to happen. When we have the paraprotein and the antibody in the cup, they bind together and you move the mobility. So this is an IgG kappa, and you can see the IgG, the blue line, the IgG has gone from G and kappa. The A still retains that paraprotein, the M retains the paraprotein, and the lambda retains the paraprotein. So this is an example of immunofixation and immunotyping. This is a nice example for immunotyping because you've got an obvious band. But in this situation, you may easily see the G lambda, but this lambda may not be quite so obvious because it's hiding in the beta. And also because the function of the way the antibodies behave, you may not have a very strong reaction with the light chains. So I would say immunofixation would be my method of choice. I think it's better. There are many people that wouldn't necessarily agree with me, but I've tried both and I feel it's the only reliable way to type monoclonal proteins. Monoclonal ANM if they're showing high concentrations, positively identify other proteins, things like fibrinogen, beta-2 microglobulin, the complement components. You can put any antibody you want on an immunofixation. You can also check that we can't see IgD or IgE paraproteins. And it's also useful to detect minimal residual disease or complete remission in patients treated for myeloma. Using antiserum, antiserum is a little bit like, fine wine or fine champagne. It's infinitely variable. And I would say always use high quality antiserum. And for light chains, we would use anti-total antiserum. It's much better than anti-free light chain antiserum for immunofixation. The anti-light chain antiserum often shows much greater binding to the free light chains than to the bound light chains. So you get quite a discrepant signal from it. We also know that one antiserum will not detect every monoclonal. There will be some monoclonal proteins that will just not work with certain antiserums. As I said, immunofixation increases the sensitivity significantly by about 10 to 20 fold. So you get a much, much, much increased sensitivity by immunofixation. And of course, that good interpretation increases the specificity. It's also worth remembering that immunofixation is definitely not quantitative. You might see a very different reaction in the IgG track than you do in the kappa track in an IgG kappa paraprotein. So here's some examples. Now, these are very old-fashioned gels. You can see they're from about 12 years ago. And these are Beckman gels, but they show, and they're not available anymore, but they show the flexibility of immunofixation. Here, we've checked for immunoglobulin, a mix of IgG, A and M. We've also checked for IgD,
IgE. So we can put a different antiserum on the track and it works fine. And here we've checked a urine for beta-2 microglobulin. And this actually, just of note, this is a very good example of antigen excess check, an antigen excess situation, where at the center of this band, you've got a very high concentration and the antigen antibody reactions become soluble and diffuse out of the gel, whereas at the edges, where the concentration of the antigen, the beta-2 microglobulin, is at its lowest, you get a nice strong precipitation. So we talked about the light chain antiserum. This is a band of kappa Bence-Jones protein, and you can see there's quite a difference in the reaction between the total kappa, that's free and bound kappa, and the free kappa. And the free kappa is there, but it's much less strong. And the same in here's an IgG lambda, lambda Bence-Jones protein. And you can see there's a trace of free lambda, but it's nowhere near as strong as the total. And so pick your antiserum carefully, but I would only use anti-free light chain antiserum very, very rarely. It's expensive and I don't think it's as good as total. And if you have a brain, you can interpret the patterns that you're seeing. So immunofixation. So what are we seeing here? So we've actually be seeing a little tiny band, a couple of little tiny bands here. And this is a normal IgG and normal IgA and a low IgM concentration. And this would be a sample that we'd think, oh yes, that IgM's a little bit low. We've got a little bit of a small zone in here. We've done the immunofixation. We've seen these two fairly diffuse bands on a fairly normal background gamma. And then when we check it with IgD, we can now see it's clearly an IgD kappa paraprotein with kappa Bence-Jones, with retained kappa Bence-Jones protein in the serum. So it improves both specificity and sensitivity. So what kind of thing causes problems for immunofixation or immunotyping? So small bands on a polyclonal raised gamma can be an issue. Multiple bands can be an issue. Oligoclonal banding also. Polyclonal gamma, and very few people ever remember this, but actually all IgGs, all the IgG subclasses, don't have the same kappa to lambda ratio. And you can see IgG4 is very skewed towards kappa. So if you've got a big polyclonal gamma, you'll end up looking at, on the immunofixation, you can see it's polyclonal. On the immunotyping, you're going to take away the G and the kappa. And on the free light chains, you might also get a skewed kappa lambda ratio. So actually we need to remember that everything isn't equal, and we need to have a little bit of knowledge to be able to understand things like immunofixation, immunotyping and light chain well. You can see IgG4 with this quite skewed kappa lambda ratio. G1 a little bit skewed, and we usually would have said, you know, 1 to 2 like kappa to lambda, but actually even IgM is much skewed towards kappa. And IgD, interestingly, is more lambdas than kappas, although we do certainly see kappas. There are things that causes problems, not so much on the immunotyping, but on the electrophoresis. And I've grouped them together: antibiotics, contrast, Daratumumab, and isatuximab. And first of all, if we talk about the antibodies, these antibodies are being used as drugs, monoclonal antibodies, and these Dara and isatuximab are used for patients with myeloma, both anti-CD38. But most biologics don't usually reach high enough concentration because of their dosage regime. But these drugs, which are given every 1 to 2 weeks, depending on whether it's initial treatment or maintenance treatment, they can reach concentrations, especially if there's immune suppression, to see them on electrophoresis. And here's an example of patients with Daratumumab. We've got 4 patients here. So this is a patient with a big paraprotein, and then post Daratumumab, the paraprotein is reduced in concentration, and the little red line, the little red arrow showing the Dara is there, obviously. Another patient, paraprotein concentration remains relatively similar, and there's a little band of Dara. And last week we spoke about paraproteins always running in the same position. You can see that the Dara is always running pretty much in the same position. Actually, this paraprotein, that may have moved a little. This paraprotein might be a Bence-Jones that's appearing here, but the Dara is running in the same position throughout. So why would we worry about Daratumumab? Well, when we first looked at patients on Dara about 6 or 7 years ago, we were immunofixing the Dara patients regularly. But after a while, we got very accomplished at looking at Dara. It always runs in the same place. On our CZD, it's at about position 251 on the x-axis. But it is important that we know what the protein is, because during a patient's treatment through their disease course for myeloma, paraproteins may appear, may disappear. There may be an oligoclonal pattern that you see post-stem cell transplant or post-reconstitution. And paraprotein, different to the original paraprotein, is in about 30% of patients following treatment for myeloma. So the disappearance of that monoclonal by immunofixation is part of the International Myeloma Working Group criteria for response. But if you get an IgG kappa reappearing, you may want to check it. Although if it's got the electrophoretic mobility of DARA, then you probably wouldn't need to. So we use DARA when we're looking for the reappearance of a paraprotein, the potential appearance of a new monoclonal, and if the patient has oligoclonal banding. They're all important findings for patient management. But we do want to know that we are seeing the protein that the patient started with, and if they've got a new one, that it may or may not be the drug. That Daratumumab shouldn't be interpreted as the emergence of a new monoclone, a new clone in a patient's B-cell population. What's also interesting is Dara seems to have quite rates of turnover in patients. So some patients have a significantly lower Dara concentration despite identical doses. And on some people, you clearly see the Dara every time they come in for their treatment or every time we get a sample. And in other patients, despite them being on the same concentration of Dara, we don't see the band. So it doesn't seem to influence, it doesn't seem to indicate whether the patient is responding. And although we can quantify it, it's not necessarily useful. If we do need to identify DARA, we can use the CB hydrashift, and also the new drug Daratumumab is also available to be, reagents are also available with Daratumumab on the CB system. You add a reagent that binds to the DARA and it changes the electrophoretic mobility from the gamma to the alpha or beta region, and the patient's monoclonal proteins aren't affected. It's most useful when we have patients with IgG kappa paraproteins running close to the DARA. If they've got a G lambda or an A kappa, A lambda, M kappa, M lambda, Bence-Jones, we don't usually need to do a DARA fix. But if we are concerned whether there's a new G kappa or it's Daratumumab, then the hydrashift is the useful test to do. And here's an example. This is a patient with an IgA kappa. This is a CB hydrashift gel. So an IgA kappa, and you can see up here there's this diffuse G kappa that's the Daratumumab that's moved up to the alpha region of the electrophoresis. And here's an electrophoresis of Isatuximab, a small band, different mobility to Daratumumab, and thanks to Sarah Lindstedt who supplied me with this photo. So this is Isatuximab, and it'll always run in the same place. And as I say, you can hydrashift it if necessary. Other things. Well, what other things can you see on electrophoresis? It's interesting because CZE detects the proteins by UV absorption, and some things also absorb in the UV, absorb light in the UV. And this is an example of a patient who was given radio contrast, was omnipaque. And when we saw this electrophoresis come off, we all crikey, there's a big new paraprotein. But then we looked at the immunoglobulins and they were, well, essentially normal. But this paraprotein is 28 grams per litre. This is one of the little strands that we need to pick up of looking at both things together, because this doesn't make sense. Something isn't quite right. So we always look at the immunoglobulins with the electrophoresis. In this situation, we checked on the gel electrophoresis where it's a protein stain. So miraculously, this band disappeared on the gel electrophoresis, wasn't there on the immunofixation. We checked the clinical details, and it turned out that the patient had had a radiological scan. They were given omnipaque, and actually when the line was in, they took blood for the electrophoresis, because the radio contrast is usually very rapidly cleared from the circulation, which is very obvious here. But on odd occasions, it can cause a little bit of a stir in the lab when you've got this big band that doesn't seem to be anything because you can't find it. But this is one of the things, you know, when I think of what will people remember from these lectures, things like this are the things like, oh yeah, that omnipate, that huge paraprotein. And funnily enough, after we saw this one of the other labs that I look after had exactly the same situation. So it does happen, not very often, but it does happen. And this is another, you know, it's an interesting example. So the top slide is of an IgA kappa, 6 gram per litre IgA kappa paraprotein in a patient known to have multiple myeloma. And the lower slide is a, you know, a band in a very similar place, but actually quite a number of antibiotics also absorb UV light. And so if the patient's on high dose antibiotics, you often get this band in the alpha 2, sometimes in the beta, and sometimes, you know, a bit faster up here, sometimes in the slow gamma. So abnormal bands can appear, particularly on the CZE, and you don't find those bands when you run the samples on the gel because you're not staining, you're not looking for UV absorption, you're staining for protein on the gel. So if you've ever got a band that doesn't seem to appear on the Immunofix, check it from CZE, check it on a gel system, and your band may miraculously disappear. We're briefly going to talk about paraprotein quantification. We've spoken about by RET total proteins for serums, CZE or scanning densitometry for separated proteins. We also spoke last week about staining able to give different results to CZE due to the differential dye binding. So we shouldn't quantify a paraprotein using the albumin concentration. Most importantly is consistency of that delimiting the bands. And we spoke last week about doing the X coordinates. Urine is much more difficult. You've got a high background often in urines, and that can confuse the quantification. And at the moment, CZE methods aren't available. And actually, what we do at St George's is we estimate, and this is a very crude estimate. Is it 50% of the total protein? Is it 25% of the protein? So we're estimating the proportion of Bence-Jones protein in that electrophoretic separation. And we would never report it as a number. We would always, it's approximately 10% or approximately 50% or greater than 95% of the total. So it's definitely not quantitative. It's only semi-quantitative. But surprisingly, when a number of us all read them and we all estimate the proportion, we're surprisingly close together in our estimates. But I wouldn't say it was a robust method that everybody should adopt. Why do we quantify those? And we know, because we know that quantification is very important. Also worthwhile remembering that the paraprotein concentration at diagnosis does not predict the disease severity. Think a small Bence-Jones protein, which is only maybe 1 or 2 grams per litre, can be dramatically more significant than a 30 gram per litre IgG. And it's important that we do always quantify densitometrically because we know that immunochemical quantifications are unreliable. Immunochemical quantifications of monoclonals are unreliable. One of the things that we all forget is monoclonal proteins aren't usually normal, intact, nice, perky, bright immunoglobulins. They're often truncated or fragmented. They can be half molecules. They can be chopped up molecules. And they will not behave as normal, intact immunoglobulins immunochemically. We also know that immunoglobulins or monoclonals are different, and the antiserum, the polyclonal antiserum that's raised for the immunochemical estimates, isn't necessarily going to react equivalently to that monoclonal protein. So we have to be very cautious of using immunochemical methods for quantifying monoclonal. And if avoidable, I wouldn't use them. And this is an example of why. These are three different patients with an Ig, M kappa, G kappa, and G lambda, 3 different patients. So in this patient with an IgM kappa paraprotein, the immunochemical is much higher than the densitometric scan, but actually going in a consistent way to the scanning densitometric results. But you may say that's okay. It's not right. These immunochemical results aren't correct, but they're going and they're giving a comparable piece of information. In this patient, the scan is actually higher than the immunochemical quantification with its IgG kappa. And at the beginning, the results by both methods give a comparable result. And then the immunochemical result is rock steady and the scanning densitometric results are increasing. We're actually getting different bits of information from these two different methods for this patient sample. And in this patient, well, I have no idea how any clinician or any lab would be able to interpret these results. We've got quite different messages. We've got both going up, one going down, one coming down, one going up. You know, it's all over the place. And these are just 3 examples of why we don't use the immunochemical quantification for monoclonal proteins. We record them at St George's, we record them on our cumulative card, but we don't report them out to the clinicians because they are unreliable. And when we're talking about looking at monoclonal proteins in an immunochemical assay, we can talk about serum-free light chains. So we also have to think about what are the basic requirements. We want them to be sensitive. We want lower limits of sensitivity for serum-free kappa and free lambda of 1 milligram per litre. We want them to be precise, certainly below 5%, preferably lower. And we want internal QC material from third-party suppliers, and preferably run at a number of concentrations, for example, low, medium and high. And we want them to be validated by an adequate performance in an EQA program. Now, I'm always reluctant to put these slides in because they should be absolute givens for us as laboratories who have accreditation and IQC and EQA. But it's surprising that a number of labs do need a little bit of a reminder that these are absolute fundamentals of what we're doing. But from the perspective of the laboratory protocols, we need to review cumulative results for patients, and we need to look very carefully if the sample is giving inconsistent results. We know our experience of free light chains is they can give flyers, they can give results that are absolutely inconsistent with the previous set of results. And for these situations, we use offline dilution because the reaction dynamics can miss a significant number of samples in antigenic settings, particularly with very, very high concentrations. We spoke a little while ago about this kappa lambda, skewed kappa lambda ratio for IgG4. And if we're thinking about using kappa lambda ratios exclusively instead of doing a urine, for example, we may start thinking about getting a bit of a funny pattern, for example, in patients with IgG4 related disease. So bear that in mind if you have a skewed kappa lambda ratio and nothing else untoward on the electrophoresis or immunofixation. We would also hope that serum-free light chain analysis is accurate, but unfortunately there's no independent calibration material for free light chain, serum-free light chains. And originally with one reagent producer, it was quite easy to say, well, at least the results are comparable. But now we have, I think Dean told me, 10 reagent producers, soon to be 11. And although these results are reported as a concentration, so a unit of mass over a unit of volume, I don't think their milligrams are the same as my milligrams. And here are 3 examples. Now, some of you may have seen these before because I've got them on a slide, but you know, every few weeks we'll find one where there's a gross discrepancy between what we're measuring in the serum-free light chains and what we can see on the electrophoresis. And just to save on time, I'm just going to go down to this patient. This is a patient known to have retained lambda Bence Jones protein. So this is the sample on 5th of January 2016. And you can see that there's a little band there, maybe a couple of grams per litre. And on that very same sample, the free lambda light chains measured 62,000, which equates to 62.8 grams per litre. Now, people say, oh, well, it's not so much the number, it's the trend, or it's the ratio. Or really, you know, we can be reporting a result of 62.8 grams per litre. That, I mean, it's just wrong. And I really struggle with these because it's wrong and we should do something about it. Another issue that we have is what bit do we look at? So this was a patient from one of our private hospitals where we had a sample. We had this sample, but this was sent to us because the patient had been for a Bupa screen and they had their immunoglobulins, a little bit of a polyclonal raised IgG, normal A, normal M, but the kappa and the lambda were both high. And this patient was immediately referred on to one of the haematologists, and they were in a bit of a quandary about what to do, how to interpret it. They sent the sample over to us. We found polyclonally raised IgG, like a normal A, normal M, and this is the immunofixation. I don't really see anything particular in there. So when you're inexperienced, what should you look at? Should you look at the kappa being high, or the kappa being more high than the lambda, but the lambda's high as well, or they're both high, or the ratio is normal? I mean, which bit of this whole mixture of results do we need to look at? And this is one of the reasons that I don't think they could be large scale introduced into, electrophoresis protein all comers, because there are issues. And here's a selection of other ones where we've got kappa-Benzone protein in the urine and an abnormal ratio. That's fine. But here we've got kappa-Benzone protein in serum and urine, and they're all pretty normal. And actually, in this latest sample, the kappa's low. It's not, they are not simple tests to interpret, because we also don't know whether we should use the absolute number, the ratio, and we've already said the immunochemical quantification of monoclonal is unreliable. This includes GAM and kappa and lambda. So if we use them, we need to use them extremely carefully. We also have high between method variation. We have significant outliers. We have varying issues with an increasing number of methods being introduced. So it's an area that we have to keep a very, very close eye on, because if we're pushing labs towards doing serum-free light chains, we need to start thinking about whether we should have standardization and how else we should adapt our practices to make sure we're pulling the way that we report them together and giving the best service to the patient. One of the other issues that we have is lot-to-lot variation, and here we see it for kappa and lambda, where both the lot changes and the kappa concentration falls, and here we also have a change of precision with, in this situation, lambda. So we have issues, and I don't think it's necessarily at the end of its development, serum-free light chains as a useful test in these patients, in all patients. So it is included in the guidelines. And how good is the evidence? How good is the evidence for paraprotein all comers? I say we have issues. We do have analytical issues, no standardization, arbitrary specificity and sensitivity, so false negatives and false positives. So electrophoresis isn't perfect either. So we have to use these tests very, very carefully. What do we do at St George's? Well, we do about 50 serum-free light chains a week. We do them for specifically for consultant hematology requests, for staging, for monitoring the benzones only, diagnosis and monitoring of secretory myeloma and amyloid, and for patients where the hematologists are concerned about them. We'll do them for neurology, occasionally we'll do them for renal medicine. We don't do them routinely, we don't do them for GPs, we don't do them as part of our initial workup, and we don't do them instead of urines. We're still pretty committed to the urine. So now, this is a bit of a dash because we have a lot to cover. So now we're going to talk about comments and communication. This is a really important part of our process. We're really good at controlling all of this and worrying about data flow, and we're worrying about turnaround times, and we're worrying about all of the stuff that we're doing in the lab. And it's almost like once the results are put onto our LIMS system, it's like, well, they're gone. They're no longer our issue. And that in part may be true. Somebody who requests a test has the responsibility to look up the results. But if you think of the number of tests and the amount of testing that is being done in your hospital, my hospital, all our hospitals, if we find a result that's very significant, I think we have the obligation to do something about it, a little bit like upvoting that you're going to be doing about questions today. If we find something interesting, we need to sort of upvote it in the clinician's mind. We need to bring it to their attention and say, this is a very significant finding, you need to do something about it. So this is a very, very important part of what we do. So when we did a survey in 2017, we asked some very simple questions like, when you report, do you report the paraprotein type, and do you report whether there's immune suppression, or what further testing should be done? And we were really shocked. We were shocked because there was lots of good practice. We were actually pleasantly surprised because there was lots of good practice. But we were shocked. For example, 74% of labs made no comment about the patient's age. So a small paraprotein in an elderly patient may be an incidental finding. We also found 73% didn't say what the underlying condition could be. They just said, paraprotein present, paraprotein absent. 40% didn't comment on the immune suppression. 50 or over 50% didn't comment on the speed of referral to haematology. And yet these are really important points where the lab is ideally placed to make these comments, to guide the requester to do the right thing. So when we're also thinking about what's the flow in the lab, so we've already said electrophoresis is very straightforward. It's not necessarily easy, and we need skills and experience and competence to do it. And actually, it's an area of the lab we seem to be de-skilling. But actually, if you think of this, the reporting may also be de-skilled because you don't have people with that training and experience and competence to make those comments. They may be able to say IgG kappa 25 grams per litre, but they don't have the knowledge or experience to extend that and give a more rounded and more beneficial, more useful report. And we would wonder about, are we using the appropriate grades of staff? Do they have appropriate training? We spoke last week about competence assessments, continual review of people's practice, and concordance studies between regions. I think they're very important components of what we should be doing. And actually at St George's, our interpretation of the electrophoresis is a high-level activity. And here it's Rachel Wheeler and Sarah Linstead. They're not, I've put the Red Cross on the bubbles because we don't work in a bubble. And you can see this is the Crew hot phone, where this phone seems to ring all day. Sarah's got her headphones on because one of them just takes the phone calls because it does. Yeah, I'm sure we're all the same. We have a lot of phone calls. But we're looking at a high-level reporting. The electrophoresis show, what does the urine show, what does the immunofixation, we try and put it together, how old's the patient, what are their symptoms, is there anything else that we can offer? Actually, I'd suggest that if any of you are particularly interested, you can look at this really excellent paper from Jill Tate in Australia about the standardised reporting of electrophoresis. It's really got some incredibly useful ideas and tips and processes to go through. But most important, we have to think that what we're doing when we're reporting electrophoresis is that link between the patient and the clinician looking after that patient. We're not there in this little bubble that says, oh, we can just stick it onto the computer and it'll go away. There are occasions where we have to take rapid action to make sure that the patient gets appropriately treated. So what would we say? What would I say? Well, we would always comment on the concentration. So, for example, a large paraprotein, a small paraprotein, with the type. We said a small IgG kappa may be an incidental finding. A small retained Bence-Jones protein will be a highly significant finding. We would comment on whether there's any immunosuppression, whether the background immunoglobulins are low. We'd also suggest the significance of this finding and what tests to do next. And actually, it's a little bit right, you know, when you were at school and writing those essays, you say what you're going to say, you say what you said, and then you go back and you say it, and then you go back and say that you said it. It's that kind of thing. What are we seeing? What's the significance? What are you going to do about it? And trying to be more specific, what should we do? Well, I would suggest that now we have this wonderful GP diagnostic tool, we should use it. We should reference it on our reports for myeloma, because it's actually linking all of those things that we're suggesting. So no paraprotein, no Bence-Jones protein, normal immunoglobulins, myeloma is unlikely. Or small paraprotein, no immune suppression, normal free light chains, often seen in an elderly patient. We've actually got the information there written down. And it doesn't ever say it's not or it is. It says, no, discuss with your haematologist. Myeloma is unlikely, may be investigated with other clinical specialties. So it's a very, very useful tool, and I would suggest that we should start giving this link on some of our electrophoresis reports, because I'm sure the GPs will find it useful, and I'm sure a lot of people in the lab will find it useful as a sort of a safety blanket in their reporting. And what sort of comments? Well, here's a sample that we saw. So this is actually what we said. A 53 gram per litre IgG kappa. There was a leak of IgG kappa in the urine. So we said serum shows a large IgG kappa. We said how big the paraprotein is and what the type is, with marked immune suppression. That's picked as well. We said the possible significance. So this high concentration, hyperviscosity may be an issue. We said there's no Bence-Jones protein, but considering the findings, urgent referral to clinical haematology. We've suggested that it's a further investigation of B-cell malignancy, e.g. multiple myeloma. We can't make that diagnosis, the haematologists make it, but putting those words in our report will make the clinician, the GP, for example, think, oh, right, okay, myeloma, yeah, haematology. We've given them all of the information for them to take this patient forward. And this is the flip side. So this is a CZE with this massive polyclonal gamma, polyraised IgG, polyraised IgA. And we said polyclonal, low albumin, the albumin's a bit low, polyclonally raised IgG and IgA with beta gamma fusion, most suggestive of persistent infection or persistent inflammation, liver disease, autoimmune disease, etc. So we've said what we're seeing and what the interpretation is likely to be. And then this is a patient with a little bit of zoning in the gamma, with two little tiny IgG lambda paraproteins, polyclonally raised, and we've called it zoning in the gamma. In a patient of this age, a little bit of a poly-raised IgA, generally unwell, deteriorating renal function, but we still say urine fermented protein, particularly if you've got strong clinical indication, we say most suggestive of recent infection or inflammation with that polyclonally raised IgA. So when we're making our reports, we're trying to guide the clinicians to what they're doing. Then two small IgG kappa paraproteins, normal background gamma, often an incidental finding. Now, at this stage, in the proof, we don't often use MGUS, and that seems to be a, Ross will talk about MGUS a little bit more next week, but MGUS seems to be the next stage on. So we would say incidental finding, urine for Bence-Jones protein, recheck serum in a couple of months, 3 to 6 months, confirm pattern and assess any progression. But we very much like the CRAB criteria. If you do have any clinical indications, and we list it out, hypercalcemia, renal impairment, anemia, bone pain, suggest further investigation. Whenever we go out to speak to GPs, we always say, remember the CRAB criteria. And they're amazing at remembering. They may forget everything else we tell them, but they remember the CRAB criteria. But it's a very useful thing for them to do. As you can see, we've noted down the IgG of 10.5 grams per litre, but we didn't report it into the computer because the IgG kappas are reported there as 2 grams per litre and 2 grams per litre. There's obvious one and then a little diffuse one on here. And then another patient, an IgG lambda paraprotein with retained lambda Bence-Jones protein. I showed you this Immunofix earlier. You can see the retained lambda Bence-Jones protein is actually bigger than the IgG lambda. You can see it best on here. So 4 grams per litre retained lambda, G lambda of 3. Marked immune suppression, so suppression of the IgA and IgM. Urine must be checked for Bence-Jones protein, but urgent referral to clinical haematology. And we actually discussed the results with, you see Dr. Barnett here, and took a copy of our little sheet down to Dr. Willis. So everybody who needed to know about it knew about it. So this patient was came in on acute medical on the 30th, and we were reporting this on the 1st to the 6th, having received the sample. So, making these comments is very, very valuable. Cumulative results are also incredibly valuable. So here's a patient at diagnosis of 53 gram per litre IgG kappa. We note down the IgG concentration, but then we suppress it in for lots of immune suppression, no Bence-Jones protein. So at diagnosis on the 29th of October 2013, this was what we found. And you can see that the cumulative results fall quite nicely, and then all of a sudden, 3, 4, 4, 4, 4, 3, and then they start creeping up. And this is quite a pattern that we quite often see. Little tiny hiccup, and then it starts to take off. And you can see that at quite high concentrations, there's a bigger discrepancy. But as the concentrations come down, the discrepancy between the total IgG and the densitometric reduces. This is the same patient here, 7 grams per litre, 10.4. So this is the patient's serum electrophoresis and the urine still with an IgG kappa. But here we've got a polyclonal pattern post IVIG, and then here we have this oligoclonal banding pattern post stem cell transplant. Dina, you've appeared. Do you want me to stop?
Got a couple more minutes, Jo.
Couple more minutes. Okay, couple more minutes. So this oligoclonal banding pattern, and you can see this is post IVIG. We've made a comment on our cumulative report, and then we've got this oligoclonal banding. So the beauty of these cumulative results, I'm going to ignore that one. The beauty of this cumulative results is you can see what's going on, and it's much easier than looking back on the computer. And then communication of results. Do you routinely contact your haematology to inform them? Yeah, why isn't it 100%? Why are over almost 40% of people not contacting their haematologists about patients with significant paraprotein? Why aren't we talking about, why aren't 100% of people contacting haematology with significant increases in paraprotein concentration. These are things that we should be able to do relatively easily. What about GPs? I mean, only not even 60% are contacting GPs looking at a brand new big concentration paraprotein. We should be doing this better. So, best practices for diagnosis and monitoring of myeloma. We have to sort out the requesting. We've got to stop these stupid requests and duplicate requests. But if we do something, we have to do them properly, but then that would help. We only have to do it once. We want to do electrophoresis every day and report the results daily. New significant paraprotein should be phoned to requesting clinicians and to the haematologist on the day of that report. And a full report within 2 working days of sample receipt. We need to sharpen up what we're doing. We need to do it quick. We need to do it better. But most importantly, we need to have communication of new paraproteins or significant changes in paraproteins going to haematology and to the clinicians looking after the patient. That robust communication with haematology is absolutely vital. When we think about the processes that we have in place, it should be what we would expect if we were the patient. And I know we shouldn't do it, but how many of you have ever had your samples taken and you've actually looked in your computer to see what your results were? You want your results quickly. Why shouldn't a patient want their results quickly? So we've covered paraprotein incredibly quickly. I'm so sorry that it's been so quick. With paraprotein typing, immunofixation, immunotyping. We've looked at things that interfere with the electrophoresis, where you need other things and the thought process to elucidate, like serum-free light chains. We talked about the reporting of cumulative results and comments, and the essential factor of communicating the results properly. Patients have to be at the centre of what we do. Request to report has so many factors. We have to try and make it quicker and also drive improvement in other groups. And the lab is ideally positioned to do this. We need to promote that diagnostic tool. We've talked about the basic requirements of post-protein testing. And it's not easy. It's not going to be cheap either. Doing something well, there will be compromises, and it may be on the speed and the cost. And if there's one thing that you can do really well, it is speak to your haematologist. They're not horrible and scary. They're usually very, very grateful that you've taken the time to phone them up or walk down the corridor and say, have you seen these results? You've got a new patient. What are we going to do about it? But whatever you do, we need to strive to do it to the very highest of standards, because we can all be patients too. Now, next week, we're going to hear about how the clinicians work to manage, how the labs work with clinicians to manage patients with MGUS. But, Dina, that's me done.
Okay, right. I'm afraid we are out of time now. So I'd like to thank Jo for her fantastic presentation today, and also to everyone at UK NEQAS who are making this series of webinars happen, and everyone who's taken the time out to join us today. I hope you have found the session both beneficial and enjoyable. This is the third of a series of 5 webinars we're putting on over the coming weeks, and you'll see on screen now the details of the other upcoming sessions. And hopefully, if you're enjoying the webinars, you'll get on and book onto the remaining 2. So in the final webinar on the 19th of May, we will be joined by our panel of experts who will help us to bring together, summarise and reflect on information from the previous week's webinars. We are also going to use this session as an opportunity to allow discussion around various cases that can be submitted by the audience. So if you do have any unusual gels or scans or results that you'd like to discuss, then please do submit them to my email address, and we will do our very best to discuss them in week 5. This session is now open for registration, so please do register if you are interested in attending. And finally, we are active on Twitter, LinkedIn, and we do social media. So we would encourage you to seek out and follow us on these platforms and keep up to date with all the activities that UK NEQAS are doing. And finally, once again, we now need to close this session, but please do take a few moments to feedback on the short survey that's going to be brought up as you close down the session. Your views and opinions do matter to us, and they will be used to shape future events, and hopefully we can continue to provide you with good educational webinars and other training. So thank you all very much again, and I hope you found today's session useful, and I look forward to seeing you virtually next week at the same time for our next webinar. Until then, stay safe. Thank you.